My background is medicine. I'm basically an internist and still working as a doctor for part-time. But I have been spending more and more time on medical education research, which is our same interest with Vishen and Madhav here, who was my classmate when we were in Dundee. And Vishnu is asking about the professionalism and because I published several papers, but this is, I think, one of the very unique ones, yes, in medical professions. Several years ago, I published in academic medicine. So I'm going to talk about my work as well as something related to tomorrow's and day after tomorrow's work of ours, which is medical professions in general and how culture matters in Malaysian context. I do my best to contextualize, but this is my second visit in Malaysia, and actually the AMU. Last time was in 2004. And to be honest, I don't know very much about your culture, so I also very much like to learn your culture from you. So please ask any questions or make comments when you would like to do that. Yes. Because I thought that my talk would be more frank, and I like to make it frank today. So these are today's contents. I'm talking about the general picture of best evidence medical education, which is some of you are very natural, but for others maybe they be new. Medical education culture, especially medical professions I'm talking about, and I'm going to introduce the Bushido and medical professions as a case from Japan, and I'm going to propose something for you. I used this slide several times before, so some of you may know it, but do you know it? What is it? It is. Yes, yes. I love Star Wars. I love Star Wars because of many reasons. Because it's philosophical, because we learned a lot, but also because George Lucas really loves Kurosawa's films of Japanese. And I feel that the movie Star Wars is a kind of a mixture of Japanese and American culture. So that's why I quoted this picture. But a long time ago, not in the galaxy far, but a long time ago, more than 10 years ago, no doctor will deny the need for evidence-based clinical practice. And all responsible professions try to keep up with research in their disciplines. For many, however, the education of the next generation of doctors is also a major responsibility, yet the same professional standards are not so commonly applied. That's in 1999, so more than 15 years ago in BMJ. And as most of you have known already, this is a paper from Ron Harden in 1999, first proposing the concept of best evidence medical education. There's a need to move from opinion-based education to evidence-based medication. Best evidence medical education, which is called BEME, is the implementation by teachers in their practice of methods and approaches to education based of the best evidence available. And since then, there are lots of discussion and debates. And I know that we have to discuss a lot more about how to use the term evidence in medical education, because there are also theories, there are also models, there are also concepts, yes. But this moment I stick to use the term evidence in my talk. And this is also from Ron's paper. In BEME, the teachers make decisions about their teaching practice on the best evidence that is available, at whichever point they found themselves on continuum. The continuum is this. So the BEME concept, we propose from opinion-based to more evidence-based. And this is what we learned in Dundee, yes, with Madhav. It's more than 10 years ago as well. But I don't know about your countries or IMF situation. Do many of you use evidences when you are discussing educational issues or strategies? Yes. Yeah. I think you do. Of course, but how about other faculty members? In my university, not many still. Yes. Yes. Yeah. Yes, indeed. Mhm. Mhm. Since 4 years ago, our team started implementing something like a certificate program in medical education. So it's a not big amount of sessions and workshops and classes, but the number of applicants are 3 times, 4 times more than the spaces. So I can say that in Japan, there are more and more young doctors or healthcare professionals who are interested in medical education and evidences. Medical education as a science, we call it. 10 years or 15 years later, yes, now we have many beaming eyes and systematic reviews, and it seems more and more medical educators are using evidences in medical education, as we discussed. And also what we found, and Vishna and I and other colleagues found that most research evidences are written in English and many are from Western countries. I didn't quote a paper which impressed me a lot, but that was in 2013 or 14 in BMC Medical Education. It clarifies that the Maastricht or the Netherlands, yes, produces the most, yes. And English-speaking countries followed, like Canada, or the United States, or the UK. So what happened in my country, and probably you have the same problem, but because of the time and the period of evidence-based medical education, we use evidences to discuss or decide educational strategies or politics. And I and my colleagues in Japan sometimes, or quite often, found it difficult to apply these evidences direct to our own cultural context, yes. And it is called or cultural dependency or context in medical education. And already we have lots of papers referring to this issue. So, this is from Ming from Taiwan, and this is from Matthew Gee from Singapore. And this is not in medical education, but in education in general, Western educational theories and practice through the university. And the last paper is saying this. I'm going to read a little bit in details. Academic proponents of Western theories and practices would most likely accept the observation that they are culturally situated and argue forcefully that simplistic notion of transfer to other contexts may be inappropriate and potentially undermine existing practice. This interested me a lot, yes, because this is what happened in my own context. How about you? Yes, please share your experiences afterwards. And this is not only my opinion, my personal opinion, but already said. It is generally acknowledged that educational methods reflect cultural and ideological values in 2012. And especially medical professions, which is tomorrow's and day after tomorrow's theme of ours. When Richard and Sylvia Cruz is from McGill University, saying when professions taught, it should be related to different cultures and social contrasts, respecting local customs and values. Before my talk, I, to be honest, say that I don't know very much or very few about your culture. Yes, I was born in Japan. I was born in Osaka, Japan, and spent most of my time in Japan. I spent only 2 years outside of my country, yeah, the UK, but I have had lots of opportunities to talk with colleagues, friends outside of Japan, like Marwan Vishnu and others. So I think I am a little more westernized, I could say, yes, compared to other Japanese. But still, I don't know about many cultures, and especially your culture. So please, again, let me know or tell me about your culture or what you think is, oh, Hiroshi's talk is a little bit weird or strange or different from ours, yes, which I like to learn from you. And yes, please. Oh, yes, please. You like to use microphone? Or somewhere? Or talk loudly, please. Yes. Drama series.
Shiro Kyoto.
Shiroi Kyoto, yes.
You remember, right?
This is what I love.
Yes.
Very
I
much.
love that series as well. So my question is actually in one of the scene in that drama where um, where the group of this so-called department looking forward for the ward visit in the morning, and where only the professor taking the elevator.
Others
Sorry,
are
it's a
taking the
lift.
stairs,
Yeah,
yes.
it's taking a lift while the others are taking the stairs.
I remember that.
And they must rush so that they will arrive first before the professor arrive with the lift. So is that I mean really practice and
Thank you for a wonderful question. Sorry, I just share with you that the movie or the drama Shiroi Kyoto is a white ivory in English language. It's written by Toyoko Yamazaki about 40 or 50 years ago, and made it its TV drama twice so far. And the second version was implemented about 10 years ago. Yes, that was what you mentioned. Yes, and there's a scene that the main character, who is Professor Zaizen, yes, finally became a professor of surgery, and did a kind of a grand round, yes, with their, how many, 20 or 30 of their junior colleagues. And because their ward is 13th or 14th, yes, floor, only as he mentioned, only the professor can take the elevator or lift to go upstairs, and the other members have to rush using steps to go upstairs. I don't think it happens very much in real Japanese practices, yes. But again, I don't know about all the professors' rounds in every 82 medical schools in Japan. So may happen. But it reflects the traditional hierarchical relationship between professors and young doctors, as well as medical students. Just 5 days ago, we had as I told you, a medical education program with my students, and word round or teaching round is one of the topics, and we discussed the same issue. But that professor, the lecturer, is saying that they are following, only 3 or 4 students are following, not a big group, at his case, yes. Did I answer your question? Yeah, thank you. Thank you for your question. If I have any more questions, please tell me. So I introduced the cultural influences in professionalism, quoted using the Cruises paper. And probably we are going to use this paper as well tomorrow or the day after tomorrow. The Physician's Charter it's one of the landmarking paper by American College of Medicine and also European College of Medicine. It's published in 2002, both in the Journal of Lancet as well as Annals of Internal Medicine. And it has 3 principles and 10 commitments for doctors to follow. The 3 principles are primacy of patient welfare, and patient autonomy, and social justice. Does any of you know this paper? I think some of you, yes, thank you. I think this is a kind of a must-read paper, yes, to discuss medical professionalism in our context. And more than 130 organizations worldwide have endorsed and translated into 12 languages, including Japanese, which is our language. And what interested me is this sentence in the paper, because when I read this paper, yes, they are very much true. Yes, we doctors have to follow these kind of rules and regulations and code of conducts, yes. And at this stage in this 21st century, have to revisit professions, yes. But I have some different senses. Well, yes, they are right, but we have these kind of things already. Why do we have to translate them and follow them? And what's this? So kind of that questions I raise. And surprisingly, the author of this paper stated the similar things. He said, or he or they, that this document represents a tradition of medicine cultures other than those in the West, where the authors of the charter, or this paper, have practiced medicine. And not many people, or very few, my colleagues read this and just followed what this paper mentioned. But this sentence really, really interested me, and I really like to answer this question or respond to this question. And yes, this is Madhava's paper, and also again the means. And already discussed about how culture influences medical profession. There's a policy of literature on the universal applicability of this framework, or constitutions of professions vary among countries or regions, mainly as a result of cultural variations. Yeah, again, think about your culture. Think about Malaysian culture. Think about your own institution's culture. Think about your department's culture, which influences a lot when we are discussing medical professions. And yes, same as yours, professions is also a very hot topic in Japan. And these are questions we have as well, how to translate the mostly Western concepts of profession present in international publications into our setting, and how to tell the international community about Japanese unique concepts related to medical process. And I am interested in both, but my talk is mainly related to the latter one. The term professionalism originated from the Latin word profess, meaning to declare publicly, is largely a Western concept, and no corresponding word in most Asian languages, including Japanese. This is what I wrote in my paper, but how about in your country? What do you think? How about in Malaysian language? And the Bushido is the one I raised to respond to the question the author of the Physician Charter wrote. The Bushido is meaning the way of the warrior, and it is a historical Japanese person conduct originating from the ancient samurai warriors, and is similar to professionalism. And actually, the Bushido is already written in English language, published in 1900 by Mr. Inazo Nitobe. So my work really got help from him. He describes the moral guidelines handed down over centuries by the samurai of Japan. It describes quite well about our culture, our code of conduct within our own context. Bushido is linked to chivalry and noblesse oblige. Have you already known that? It's a very old classes for Europe. But it has a basis in Buddhism, Confucianism, and Shintoism, which are different from Western ones, but also different from yours, I think. Yeah. And Bushido has 7 principal virtues, which are rectitude, what we call gi, courage, we call it yu, benevolence or jin, politeness, rei, honesty, sei, honor, meiyo, and loyalty. And not only describing the Bushido concept related to medical professionals, I did a very tiny survey because the reviewer asked me to do so. So I did a small internet-based survey, and sorry, it's a low response rate, but I included real doctors currently working in Japan. So these are the results of the small survey, and about the gi or rectitude. 88% of the doctors or respondents say that yes, the rectitude or gi is still alive in their daily clinical practice. and saying that you do not keep working as a hospital doctor if I pursue the financial benefit. Yes. So key is something which is against financial benefit. Courage, doctors who went to rescue people suffering from the 211 Great East Japan earthquake and tsunami is a good example. It's a use of courage. And 62% of the respondents say that they are still alive. Benevolence, there is no medical practice without this. And this is another TV drama. It's called the Jin in Japanese. Yes. And the politeness and Rei, I always try to be polite to patients. We must be polite as a member of society also. So it's not only a medical education issue, but it's in general. The politeness is necessary. Honesty, sometimes the end justifies the means. So sometimes we have to tell a lie. Yes, this he said, or she. I feel honored to be a doctor, the mayor. Loyalty, surprisingly, lower than 50% say that loyalty is still alive. So we have in crisis in loyalty. Now I feel we have less and less loyalty, yes. And I think this is a survey about more than 5 years ago, so I think we have a lower score, I guess. If you have similar problems, please discuss later. And factors behind the differences between Bushido and the physician charters is a social contract between medicine and society. We don't have the kind of a concept of contract, yes. So that's one thing. And the concept of yes is foreign to Japan as implies a covenant based on principles Christian religion. Again, I'd like to ask you, how about your country? How does the concept yes, affect, or how is the concept of contract relate to medical professionalism in your context, in Malaysian context? As I told you, it's strongly influenced by Shintoism, Buddhism, and Confucianism. And again, same as the TV drama Shiroi Kyoto or White Ivory, yes, young people are expected to show respect for elderly people. How about here? Yes. So how much extent? Yeah. It's to some extent, yes, but we share some differences probably. Yes, we can discuss more. Demonstrating politeness to an older person calls for a type of difference on the Kawata Pauta, which might not be seen, sometimes to be seen in Western cultures, I guess. Sorry, I have to modify that. But I think ours are very strong, yes, and sometimes causes problems in professionalism. And also the extent to which the culture values individualism, yes. Loyalty influences doctors to give greater weight to the interests of the group in cultures like the Japanese one, which value collectivism. Again, how about in your country? Yes. And talking about the ethics issues, there are two schools of ethics, one which is deontology and the other one is virtue ethics. Deontologists judge according to the adherence of ethical principles, focusing on doing, whereas virtue ethicists judge according to the character traits of the actor embodies, focusing on being. And I found that the physician's charter is more on principle ethics, so deontologist approach, focusing on doing, whereas Bushido is more virtue ethics, focusing on being. Reminds me of again another Cruz's paper in 2015 or 16, I forget, in academic medicine. He added being on top of the Miller's pyramid. Yes, and so being and doing are also one of the hot topics in medical education. So I ask you these questions, but Malaysian culture must have its own concept similar to professions. So my question for you is, what is that? Which I do not know. How is it similar to and different from Western concept professions? Since I came yesterday, or very early today, I found that most of the signs, letters are both English and Malays. Is it correct? But I also found that English first and Malays the next. Yes. in which language do you use more often? In academic field, probably you use English more. But how about communicating with patients? It's more Malays or some English? Both? Malays, yes. And depending on the patient, yes, yeah, of course, yes. And yeah, this problem is similar to ours, but you know, we communicate with our patients in Japanese language. Yeah, so think the medical professions is very much linked to the doctor-patient relationship, and it is basically based on our own language or our own culture. Yes. So when we discuss medical professions only in English language, it might cause problems. This is my personal opinion, but what do you think? Yes, I don't know about your culture, but. So when discussing teaching and assessment of professions in Malaysia, I would recommend do not apply existing framework directly, yes, which I'm going to tell tomorrow and the day after tomorrow as well. Discuss what you have had in your own culture, which I do not know, again. What is it? Tell me, please. And do not follow what medical education in other culture, including ours, yes, developed, but do follow how they developed. This is, I think, important. Yeah, for example, education outcomes. Yes, when implementing or developing curriculums, it's easy to use other countries' frameworks on the outcomes, like CAMS, on ACGMs. But I think it's important to develop our own curriculum outcomes or competencies by our own, with our own language, yes, through our own thoughts and ideas. What do you think? And also, I like to recommend discuss more on Malaysian culture and religion. And this is what I love. Are there many cultural anthropologists in this country? Some of the public health universities, right. I see, yes. I have been working with cultural anthropologists for the last 10 years. And, but I becoming more and more interested in this collaboration because first, they are experts in qualitative studies. And second, they are also interested in learning. But personally, because they are expert in culture, I learned, and I'm learning a lot from them. And they are learning as well, because they don't know much about medicine. Yes, especially what happens in real clinical practices. Yeah, if I have another chance, I like to talk about this stuff, cultural anthropology. I did a talk in the last APMAC in Singapore about my collaboration with cultural anthropologists, but it's quite unique and it's interesting. And also, teaching and assessing behavior and social science is one of the topics in medical education recently, yes. Yeah, that's another talk. But coming back to medical professions, I think you Malaysian medical educators know what it is, and I do not know. Have you heard, is any of you are experts in language or linguistics? This is from the, yes, philosopher or the experts in linguistics and social French philosopher is signifiant and signifier. And signifier is the concept or the meaning, whereas the significant is the words or terms. Yes. So, yes, please. Yes. Definitely. Bilingual. I see. Mm. I see. I see. Thank you, Vishnu. Yeah, coming back to the French philosopher socials. Um, yes, I think we have to be more conscious of similar concepts and different words. Yeah. Like competencies and outcomes are very similar. Or faculty development, staff development are similar. Yes. Probably, yeah, Bushido is one of the examples, and only limited to the Japanese context. But I think, and I'm sure that you must have something unique terms and concepts using in your own culture related to medical professions or professions in general, or code of conduct in general. And I really would like to know what they are. Again, this is my personal opinion, so you can have different opinions afterwards if you have. Think of their concepts when encountering new educational terms originating from other countries. Yes. It's easy for us to just import and share with other colleagues. But I found that it causes many problems if we don't think about the context. Be reflective medical teachers is also very important. Reflect on our past experiences. Think commonality of problems and consider their transferability. Yes. So I do not want you to apply the Bushido concept into your own culture. That's not what I want. Yes. Yes. The Bushido is a case of Japan. So again, I'm repeating the same thing, but I like to know what you, Malaysian culture, have its own, yes. And do your best to translate educational evidences appropriately with considering our own context. And this is the subtitle of my talk, How Culture Matters in Teaching and Assessing Professions. And hopefully we're going to keep discussing tomorrow and the day after tomorrow. And I think that we have not verbalized our own context by our own words enough for other, mainly Western countries. What do you think? Yes. That's what we share within the Asian Pacific Medical Educators Networking, yes. And especially for me and other some Asian medical educators, there is a language barrier. So we don't use alphabets. We use Chinese characters, so it's very different. Yes. So it's a kind of painful process, but it's a time of globalization, so that's why we are communicating with each other, yes, in English language. So it's time to share customs and values of our own culture with people in other countries, which is now what we are doing. Again, and this is what Vishnu and I and our colleagues are doing. Do more research from our own regions and publish it in English to share. And scholarship in medical education is important, and that's how and why we developed the so-called APMINet, the networking, to develop more scholarly work in medical education. So there are 2 slides more left. But these are take-home messages of mine. Culture of being has been widespread, as you recognize already. Medical education, especially medical professionalism, is very much culture dependent. I hope most of you agree. And we Japanese medical educators use Bushido as a framework. Again, I have to say that this is not the framework. Yes, this is one of the frameworks. Yeah, and after publishing my paper and after translating my English paper into Japanese by myself, I have lots of papers in Japanese language of counter-arguments. Yes. Some are from medical educators, others are from cultural anthropologists, which is interesting. And I recognize that there is no one clear, definite answer in medical professionalism. So I think it's natural to have a wide range of discussions and talks among us. so this is, again, I use Bushido as a framework in discussing medical profession. So seek what you have in your own context. Yes. And when using educational evidence is developed in other countries, and mainly Western countries, yes, we are supposed to think of their concepts or signifia and appropriately translate them as reflected teachers. We require to share customs and values in our own culture internationally by publishing medical education research in English. And Richard Hayes is here. Maybe publish can help. Hope. Yes. Okay. So, thank you very much. And I think we have 15 more minutes. So I'd like to invite your questions, comments. So thank you very much. Yes, please.
Tell the patients about the diagnosis, especially it's the terminal year disease. For probably usually an elderly person, they usually would disclose the information to their close family rather than to the patient.
Close family first.
Yes,
Then the patient.
they will tell the family members first, and that I experienced it for myself as well. When my mom's sick, so the doctor talked to me rather than talk to my mom. You know, but that goes against with the patient confidentiality
Indeed.
concept.
Indeed. Yes.
That is by the West. So I mean that because culturally, family, it's in Chinese, the family bond is very strong.
Yes,
All right,
I know that.
or in Asians, well, not largely.
Yes.
All right, so the doctors, in fact, feel that they're responsible, okay, to tell the family members rather than the patients themselves. So when we teach our students regarding patient confidentiality, this sometimes can be conflict.
Yes, yes,
in
indeed.
this.
We have the similar problems, and in our context, it's different among generations as well. In the past, it's a kind of a never happens things to tell the patients the true diagnosis if they have a kind of a cancer or end-stage diseases. Whereas recently, more and more doctors are telling the truth to the patient first. Yes, and what we are doing is that asking patients first when they come to the hospital or the clinic, whatever their diseases are, or undiagnosed stage, and get their kind of what they want to be informed, kind of that. Yes, but yeah, again, we have more and more patients with dementia. And in that case, it's more difficult. And also, as a practicing doctor, I also think it's a problem to decide who is the key person to tell the first. Yes. And what are the relationship between the patient him or herself and him or her. Yes. But it's kind of a, I think this is my personal opinion, but we have to discuss and talk with patients and patients' families. Yes. Oh, madam, use it.
Thank you, Vishnu. I think this is a special area which has a lot of problems. Now, for example, now sometimes doctors don't divulge the information to the patient directly because they are scared. They don't have the skills of doing that. So if that is the case, that should not be hidden behind the culture. For example, now I did a study on taking consent from patients, and usually the junior doctors are taking consent. And what we found out was they are giving less information about the procedure to patients. That's the area which is lacking. When we asked from doctors, what's the reason? Actually, they didn't know the good and bad, the adverse effects of those procedures in full to disclose. So what they say is they don't, the patients are scared if we tell the dangers of this procedure, therefore I'm not telling. That's the covering that they use. But the actual reason is they actually don't know the adverse effects of doing it, because they are usually the consent taking procedure is delegated to junior doctors in certain settings, and they don't have the enough knowledge to do that. The culture is, we need to respect the culture, but most of the time in professionalism, what I understood from my research is that they use culture as a screen to hide behind their actual lapses. That should not happen, right? If we, who do you think the best person to divulge the information to the patient? The doctor, not the family member, because they might interpret. For example, I had a close relative, and he had a lymphoma, and doctor has told the wife and the other family. They have gone and said leukemia, which is totally different, and the prognosis is different. And patient got to know that he has leukemia. He was telling me that he has leukemia, right? So that's the management, everything is different, the lifespan, everything is different. So the best person to divulge the information to the patient is the doctor, nobody else. And I think the best thing would be to ask patient, right, whether you would like to know about this, or should we discuss with the family and make arrangements. So that skill need to be instilled to medical students or pharmacy students or whatever the health profession, the professional that we are training to deal with that. Because that's our duty, I think. Otherwise, people say it's culturally we don't. For example, ethics. Now, a doctor was presenting in a national conference in Sri Lanka, and he was telling, in our context, patients are not expecting us to get consent. If they are admitted to a teaching hospital, we can use them as teaching material. And the question I asked was, did you ask the patient whether you like to be used as a patient without their consent, right? They have not asked it. If they ask, the patient will say, yes, explain to me what's going to happen. Explain to me why I'm using. So most of the time, the thing is that we just inculcate the technical skills and all that. They are not confident enough to have to exert their social skills in getting consent and dealing with these issues. So that's the main problem most of the time that we have. And Hiroshi is right. Professionalism is culture dependence. I think there's a series of publications that we have produced to show that it's that. However, we have, if you examine professionalism literature, we have gone beyond that. It's about developing the moral identity. It's not developing professionalism of anybody. It's about developing the moral identity. Right? So that's beyond developing certain competencies. Right? So it's not like that. So we will discuss that when time goes on.
Adding to Madhawa's comments, yes, please.
Thank you so much. Thank you very much, Richard. First of all, one comment. Malay word for professionalism is made very easy. With little change in the spelling, professionalism remains professionalism. Unless you go into ikhtisar probably. I'm not Malay, but having been lived here for many years, I know another word is ikhtisas. So we have to find out the insight into it. So one comment, looking at the comment and a question to you. So looking at the cultural aspects in Asian culture, mostly we hide say patient is in a terminal condition or a serious diagnosis is being made, is hidden from the patient, is told to the family members and all. And then extra care provided to such patient. He's always confused, what is going on with me? Why this family has suddenly become very empathic towards me, and you know, the entire family taking extra care of me, and I said, he's always confused, go back to the doctor and ask, what is happening to me? What is going on with me, right? Why this? So in this situation, don't you think the evidence-based medicine will offer at least a guideline in such situation in culture which doesn't really goes well with the patient's privacy and patient's rights to know the first person to know about himself, whatever the terminal condition or the serious condition. So don't you think the evidence-based medicine is a good guideline for that?
Yeah. What's in my mind is that the kind of a dichotomy between individualism and collectivism, and if we have a kind of a tool to measure or evaluate the patient's conditions or patients, including their families, how individualistic they are or how collectivistic they are, it may help. That's one of the things in my mind. And following Madhavan's comments, thank you, Madhavan. My talk about Bushido and medical profession is very much based on so-called cultural relativism, which meaning that each culture has its own uniqueness and differences. Whereas if we follow cultural relativity too much, yes, as Madhavan mentioned, we cannot do anything. We just stopped. And we easily to admit anything, yes, some of which are dangerous or not good in natural sense. So that's a downside of cultural relativism. And also I'd like to introduce one of the counter arguments I got after I published my paper, which is Bushido paper is very much essentialistic. Actually, she is also one of my best friends, counter-argued me, is that Bushido profession is essentialistic, which is problematic. It only, not only neglects diversity within Japanese culture, but it incorporates Western discriminatory gaze for the Orient. Have you heard of the term Orientalism by Zaid? Yes. That is also an issue I'm now raising. And this is, I'm sorry, this is what I talked in the last APMEC. And essentially is something difficult to understand, but if you have time and interest, yes, please look at something like Wikipedia or some of your papers or books describing what essentialism is. And probably that is also another downside of my talk or weakness. Ah, yes, please. Okay, thank you.
A very interesting talk. Thank you very much.
Yeah, wait. Or you can use it. Yes, let's use it. I'm going to wait.
There was a yellow light on it. Yeah. My question is about pluralism. So pluralism, multiple cultures in one society.
Yeah.
So what we might call, I don't like the terms Western and Eastern because I'm an Australian. I think I live in the East, but we have allegedly Western values. But Australia is a good example of how we have many cultures coexisting.
Yes.
It's an immigrant society. A majority of Australians were not born there. They may have migrated there. America is the same. Canada is the same. United Kingdom, I've lived in the United Kingdom, and Australian and United Kingdom cultures are quite different. It took me a while to get used to that. And even within the United Kingdom, you have different regions with completely different views of what to do. I'm not quite sure what degree of difference there is within Japan, but do you have any comments about how countries deal with significant minorities who have different cultures? Because we have to train doctors to work with the patient's culture, not their own. And I think that's the challenge for medical educators.
Indeed. Yeah, Richard, thank you. Discussing and thinking about this theme and topic for the last 3 to 5 years, yes, I noticed that this is also a problem or the issue of how to deal with minorities, yes, within our own culture as well, but within other countries. And this is my personal opinion, but many immigrants, yes, in Australia probably, and in the UK or other English-speaking countries, are trying to adapt its majorities. Yes, this is what I feel. And in the 2 or 3 years ago in the AP America Asian Pacific Medical Education Conference, several Canadian medical educators organized a symposium about cultural diversity in medical education. And what interested me is that all the speakers are from Canada. And I don't think it's possible to discuss cultural diversity by speakers from one country in one language. Yeah. And then my interest is going to the language barrier stuff. Yes. We are communicating in English language today. I'm speaking English. And you say that in Malay here, you are speaking 2 or 3 languages. If we choose one language and to express our own ideas and thoughts in this case in English language, we are losing something as well. What cannot be expressed in English terms. So that's what I have in my mind. Yeah, and, sorry, Richard, that's my best to respond.
But maybe I can try to ask that question with the minority groups, and if you say minority groups are recent migrants, then that thing about adapting, and in fact access to healthcare, would put them in a way that they are the susceptible group, that they will adapt to whatever is given because accessibility is an issue. And so whether the healthcare system is alert or aware of these needs. But I'd like to offer another perspective, and during AME, the last AME, we did a workshop on clinical transition across borders, and Trudy, myself, Richard Fuller, a few of us were in that. We were facilitating that workshop, and there were many perspectives on what the students, when they transition as a medical student, like IMU's model, what challenges they have, or Maastricht was having a model where they rotated amongst different countries in Europe. And we also talked about medical doctors and other health professions who move from one country to the other. But Trudy asked a very pertinent question. We talk about global movement, health professions and everything, but do the patients want a person from a different country or cultural context to be your health profession? And I do raise this because some of the students who have transferred have told me, with the IMU model, that they have been in rooms where they will say, I don't want to be treated. Now, it's not a majority issue. It's a very small, 1 or 2 stories. But this is a challenge also. So having to go back to that, and I find the problem is it's a very emotional issue also.
I think so.
And it's becoming increasingly a emotional issue. Now,
why?
Why? And maybe because people don't speak about it. I like to raise, and I like to hear from some of our colleagues in IMU. I discovered the concept of muhasabah. There are some Muslim colleagues here. And that is about reflective practice. So this is in Islam where before you take an action, you reflect, and then after you reflect. Now, is this acceptable in the kind of society for us to say that I, as a Muslim physician, I'm practicing this? Or the fact that if the moment you say I'm a Muslim physician, people say, oh, they have a different perception. Don't bring religion into this when there are some positive characters. I have no answer, but I think this is the problem. Maybe I put more fuel into the fire, but anyway. Any other questions?
Can I add one more comment? And dealing with minorities, again, is becoming bigger and bigger in my interest. Thank you, Richard. And also the concept of power relationship between doctors, not only doctor-patient relationship, but the teacher-student relationship influences a lot, yes. So what I have talked today is about kind of a, how can I say? I felt that there is a power, yes, from a Western world imposing, or not imposing, but we Japanese automatically following the Westerners' ways of doing, yes. And probably I thought I would like to do something on, or I'd like to know what's the background of our behaviors or something like that. And also, it's now the globalization and I feel that the cultural diversity is becoming smaller, yes. Yeah. Another thing is the critical theory as an epidemiological standpoint. Yes, that's also becoming one of my interests. Yeah, in discussing power relationship between teachers and students, or dominant cultures and minority cultures. Yeah. If you have some thoughts and ideas, please share with me.
So Hiroshi will be with us for the next few days and as a peak reviewer. And so Richard is also here, not only as a peak reviewer, but also our visiting professor. So it's about, actually Hiroshi, thanks so much, because I think that the talk that you gave really, I realized when I spoke just now, I was using the word I, because it becomes a bit personal. And it's natural because it's about your moral identity, and many things come into it. And we cannot do everything in the training of our health professions, be it medicine, dentists, dietitians, nutritionists. But I think what we can do is at least be facilitators in that transition, and just aim to do better. So thanks so much. You raised a lot of good questions for us to discuss. Next 2 days will be very exciting because we'll be actually looking at one limited angle at the curriculum and how we deliver, actually. But there's more to it. We will see from that discussions how we can have some actions. It's a journey. It's a journey, and we'll do that. So thanks so much. And please, let's give him a very good hand, a big hand. Sorry.